Hello, we are the Association for Child and Adolescent Mental Health, or ACAM for short.
Hello, everyone. Welcome to the ACAM event of 2022. We are very pleased to have a 1.5 hours event today on the journey of becoming a child mental health professional. World has 1.98 billion children, according to the World Bank data up to 2019 for the age group of 0 to 14. And if you consider for 0 to 18, it will be much more. And the prevalence of child psychiatric disorders in India, if it's community-based, it's around 6-7%, whereas school-based surveys often estimate it around 20 or more percentage. So there are only 9,000 psychiatrists and 1,000 clinical psychologists in a country like India. Today, we have a population, we have an audience who are not only from India, but from around the world. So welcome to all of you. And we will go through a journey with some of the experts who had started this professional accreditation in India, Professor Shobha Srinath and her team. Along with that, after we listen to the keynote address, we would have a panel discussion with Professor Satyaraj, Dr. Nitya Purnima, and Dr. Amit Sen, all of whom have been practicing as child mental health professionals for considerable length of time. So I would first welcome Professor Vivek Agarwal, who would be chairing the keynote address to formally introduce Professor Shobha and Soumya. Of course, Professor Shobha does not need any introduction to most of the audience here, but over to you, Professor Vivek.
Thank you, Dr. Dutta. Good evening, everyone. It's a great pleasure and great honor for me to chair this session on a very important topic of choosing career in child and adolescent mental health. As Dr. Dutta said, that Professor Shobha needs no introduction, a very eminent child psychiatrist. But briefly, I will introduce her that Dr. Shobha retired as senior professor from Department of Child and Adolescent Psychiatry in CAMHS, Bangalore. She, along with her colleagues, was instrumental in starting the first accredited super specialty training program in child and adolescent psychiatry in India. So DM in child psychiatry, first accredited in CAMHS. Along with her, the other speaker will be Dr. Soumya Bhaskar. Soumya is a child and adolescent psychiatrist, and she completed her DM in child and adolescent psychiatry from CAMHS, Bangalore. She runs Insight Clinic at Coimbatore, which works with children, adolescents, and families. Soumya is a feminist and is drawn to working with young women with anxiety and neurodivergence. She likes working on creative, collaborative approaches to therapy. She is currently exploring narrative practices in psychiatry. So we have two very eminent speakers with us. So without taking much of your time, I request Shobha ma'am to take over.
Thank you. Thank you. Am I audible? I'm happy to be here.
Yes, ma'am. Yeah.
It's a pleasure to see very familiar faces. I almost always wish nowadays that one could meet face to face. But if it was, a hybrid model, I understand, is the best under the circumstances, especially this particular kind of meeting. So it's a pleasure that I say a few words today, along with Soumya Bhaskar, a junior colleague of mine. We'll take you through about half an hour of whatever we have to say. And then it'll be interesting to listen to the panel, which I'm looking forward to. So I will screen share and get on with the presentation. Okay, here we are. And our plan is that I'll speak for some time, then Soumya comes on, Vivek, and then I come on again and I end it. And it would be good if we are reminded if we are running, over time. We'll try not to. It's just 2 minutes after 7, and I think we should finish at 7:30. I think we have 30 minutes between us, isn't it? Yes, yeah.
Yes, sir.
I'm not going to talk about this because Dr. Datta just mentioned it. A study that we did shows about 12% as the overall prevalence in the 14 to 16-year-olds. And then we all are aware of the huge treatment gap that just staring in our face. And I do understand that this is not only in the developing countries, it's there in the developed nations also, that there's a very significant lack of child and adolescent psychiatrists. So this is, of course, a very sad number. And that's what we're going to talk about. I won't spend time on the evolution of clinical services in India. Enough is written about it, and that's not exactly the brief of today. But I'll talk about the challenges that occur whilst working with this population. And when we talk about the challenges, I would like to spend a little time on this model, the ecological model of Dr. Benner. And you can see the amount and the impact of what all the systems have on the child. And a child is a vulnerable person. And so if you're working with this population, other than the genetic, and the biomedical, and the biological makeup, you have a whole lot of other systems which impact a child. So anybody who works with this population will willingly have to take this into account. I mean, straight away, then this poses a big challenge because that's not what our routine medical system teaches us. We largely do with illnesses and what we can do for the illnesses, not the ills that surround our children who are bombarded with all kinds of events. And trauma and what trauma does to a child is something that's only now becoming more and more clear. When we were young students, that wasn't much of a topic. But you can see now the impact of what happens to children, how they can be traumatized, what challenges face anybody who wishes to work in this area. That's huge. So the important thing, therefore, is that one needs a lot of time and patience if one is going to work with this group of people. The time and patience goes about this way. I have a friend who's a general psychiatrist who tells me that as I enter my OP, I glance and find out how many young children and adolescents are sitting in the waiting room. Because if I see children with their parents and an adolescent with his parent, then I know that the time I need to give them is double what I would if it was an adult male or female that I would see. And he went on to tell me, well, if I have to spend double the time with the kid, with the father, with the mother, sometimes separately, then will I charge them for that much of time? No, I can't. So he says that involves enormous time and patience. So he says, I very carefully try to screen my population and try to call them all on one particular day so that I don't get hassled as far as time is concerned. Multiple informants is the other issue. All of us who work in this area know that multiple informants are mandatory, which means that you need time. The other big challenge is the developmental issue, whether it is in history taking, talking to the parent, talking to the young person, discussing treatment, discussing outcome, prognosis, whatever developmental issues informs this. It is there almost always something that you have to constantly remember. And of course, that's what makes it more interesting, actually. And then we talk about medication. Now, medication is the simplest and the easiest thing to do. But for child and adolescent work, medication is just one arrow in the quiver, just one small arrow in the quiver. I remember a study, an audit actually, that was done by the current director of NIMHANS, Pratima Murthy, who was a young resident with us. And she did an audit and looked at the interventions done for children in the outpatients, child outpatients, and interventions done for children and adolescents in the inpatient clinic. And what we found was, 45% or so of children in outpatients were given medications along with other psychosocial management techniques. 80 to 85% of the inpatient population of young people needed medication. And remember, in India especially, the child and adolescent person also looks after children with developmental disorders. So intellectual disability, ADHD, SLD are all looked after by child and adolescent people. So we have a whole population of them too. In spite of that, only 44 to 45% of the outpatient needed medication. So you can imagine how labor intensive and time intensive and the issues that occur when you handle this population. So medication is just one part of it. And then the biggest part of course is the presence or absence of the multidisciplinary professionals in your team. The lack of it is the bane of most of the departments. So these are the challenges that one has while working in this kind of a setup. Now, it will be a long time for us to get enough psychiatrists. Forget about child and adolescent psychiatrists. So the chances of getting child and adolescent psychiatrists will happen when the child psychiatry part of general psychiatry is good. So there are departments where the child psychiatry part itself is not good enough. So if you have 40% of your population as young people, almost all of the people who need help, the young ones who need help, will reach a psychiatrist who's done a general psychiatry training. And we know that only a very small percentage of those who actually need treatment go for treatment or get treatment. So it behoves on large teaching hospitals to have a section. They must seek to have a section because their general psychiatry training has to be good as far as child psychiatry goes. And it's only when a general psychiatry training program, or say a MD psychiatric program, has a good amount of child psychiatry, will the person in training understand what it means. So we are talking about a need for people to man the Department of Psychiatry where an MD or a DPM training program or a PG training program is going on. I am talking about it as child psychiatry, but it also means we are talking about clinical psychologists, psychiatric social workers, all members who are all in very great short supply. So the challenges that departments of psychiatry must take up, I'm sorry, it's a very busy slide, is that if we want people to specialize in child and adolescent psychiatry, then there must be jobs for them. If there are departments who are asking for child and adolescent psychiatrists, then there will be a chance on a motivation or an interest for people to take up these positions. Else, people who get trained in child and adolescent psychiatry look elsewhere, because after training intensely for a long time, somewhere from 1 to 4 years, and then you are not able to work in a setting in your own country, then a lot of them want to go out because that's where they want to practice. They want to do child work. But if departments of psychiatry are looking for teachers in child and adolescent psychiatry, then we have a chance. The other thing that I wish to say is that informed heads of departments are sometimes thwarted by administrators who see the specialty as being labor intensive and not remunerative. So they too, big hospitals also see that the kind of the specialty can't pay for itself because it wants more people. And therefore what happens, it's not an interesting proposition to have a department or to have people working in this area because they need a team and there are no machines. There are no investigations that can be easily done. Even more disheartening is the situation where there are people working in child and adolescent psychiatry, but they have no psychologist, no social worker, no nurses who can work with children. Medication then tends to become the first resort, which we know ought not to be. So I have spoken to many departments and I've asked about the recruitment of clinical psychologists and psychiatric social workers. They are rarely there. Even if they are there and they're advertised, they are so poorly paid that they get no applicants. And there are clinical psychologists and psychiatric social workers who are good at their work. Now, why would they work in a department when they could as well work outside? So you will find that the ones trained are not respected or paid enough to want to come to big institutes. And therefore, it's a chicken or an egg story. And there's a great need for departments and people who take decisions and administrators to think about what they can do here. So if you're doing your post-graduation psychiatry in any department in this country, the National Medical Council expects that you have a 3-month posting in child and adolescent psychiatry, you have a 3-month posting in consultation liaison, and 1 month in clinical psychology. And I know that many departments have difficulty in anyway, they don't have it in their departments. They have difficulty in sending them out because it decreases the manpower in their department. But we know that residents who kind of make a noise, who say they want to do it, they have to learn, then they are asked, they are allowed to go outside, and they come to institutions such as ours. So residents must seek and ask for placement, because even in consultation liaison, even in clinical psychology, a large part of the work is child-related. So there is a chance that a person who gets this 6 or 7 months actually gets a good enough training in their general psychiatry, in their MD, in child and adolescent. The reason I say this is that's the only way that they can get interested in the subject. So in CAMHS, I have written this as 40, but I'm sure by now there are many more institutes. Many institutes post their postgraduates in psychiatry, psychology, social work, and nursing at the postgraduate level for a placement in the Department of Child and Adolescent, ranging from a few days to years of training. From within the country, we have people from departments who fund themselves. They come by themselves. The colleges don't give. But when they come from outside the country, from other countries like Nepal, Cambodia, Sri Lanka, and many more such countries, they are funded by their governments or by WHO. Now from Nepal, people are sent for their DM degree. So it is possible for India to be a hub for training. It need not be a full-fledged diploma or a degree. It can just be an orientation, a 6 months fellowship, which is also entertained. So there is a possibility, therefore, of a young person being exposed to what it means to be in child and adolescent psychiatry. So many of these young people, when they have stayed with us for some time and when they go back, they always ask for their feedback. It's a mutual, they give us and we let them say what we think. So what do they say? Many of them say, we did not know there was such a variety of cases in CAP. They have learned that children and adolescents can be managed in different settings, schools, homes, hospital, outpatient, inpatient, that parents play such a big role. And many a times they are surprised that parents who are able, and many of them are, actually behave like co-therapists. There are only a small number of parents who are difficult, who are toxic, but by and large, most of our parents can be trained to do what they should. That's the feedback is also that they are so surprised that so many team members can work on a case. And we always say, if the multidisciplinary team keeps their ego outside the door and comes in to look after a case and their family, lots of things can be done. Working towards one case, one child and family by a group of different people who have different things to offer is really a joy to perceive. And the outcome is so many times very good. So they also understand the role of society. What can a teacher do? What can a coach do? What can a friend do for a young person? Many of them tell us that I realize I'm very good with children. Some of them say, ma'am, I just don't know how to play with a child. I don't know how to talk to an adolescent, but I learned something about myself during my posting here. They also, this is a very common feedback. They say they learned from watching how the consultants and senior residents handle families and children under routine and difficult situations. Many of them tell us, we pass an exam in child psychiatry because we have questions that we learn from our books. We don't need anybody to teach us. But actually to see how a case is managed, Only when we see a model before us, when we see something happening, do we learn. And of course, many tell us that they want to come back to learn, and many look forward to taking up child and adolescent mental health as a future. Academic specialty trainings, we know there are many centers, and we hope there will be many more in India. So most of the people, and many people who are on the panel here, who are chairpersons here, all belong to this category. So most of the people who take up a full-time career in child and adolescent have certain qualities. They are passionately interested in working with children and families. They're interested in therapies, in child development, in family work. Most of them would have sought and trained in child and adolescent mental health by going out, going elsewhere, but they would get additional training. Many of them have mentors whom they keep going back to from time to time. And this is not just in child psychiatry. I mean, in any profession, it's wonderful to have mentors to go back and come because it's a continuous learning process. They tend to be curious and can put up with ambiguity. They can work in a team without feeling threatened. And they are likely to be creative and have a sense of humor because they do work with a population which requires you to be on your feet. I remember that I used to read the sports page before going to the OPD many days regularly because most of our children are interested in sports. And to know something and to be able to get the child to talk, I needed to say something. I needed to know something. So there is a great need for us to be different, to be a little different. And I think child and adolescent people are a little different. The practice of child and adolescent psychiatry in a tertiary center like CAMHS is different from what actually can happen outside. And these are some of the stuff that our postgraduates who pass out tell us. So the team in child and adolescent psychiatry is an important issue. And for us, the most important group of people are the clinical psychologists and the psychiatric social workers. And because we do a whole lot of work in intellectual disability and developmental disorders, we need speech language people, we need occupational therapies, and we need a whole lot of non-medical members on the team, all of whom are good at their work. So they too need places in which training occurs. So it is not just psychiatry, but it is choosing a career in child and adolescent mental health. So we need training places in many of these specialties too. Now, there are a lot of professionals who have been trained in CAP. In CAMHS itself, we have at the last count, I got it, was 33 DM students have passed or are passing through us, 33. 20 of them, 20 are postdoctoral fellows. Many of the postdoctoral fellows who did 1 year of training went on to do a DM. That means they did 4 years totally. Now we know that after this many years, you better be a teacher. There are lots of people who just do 1 year. Many of them go back to general practice and they work with children and with adults. But what happens to people who do their PhD in clinical psychology, PhD in psychiatric social work in a child topic? Now they are experts in that particular field. So in this connection, I have my junior colleague, Dr. Soumya, who's going to talk to us about her journey after she's done her DM. So Soumya, there it goes to you.
Good evening. Thank you so much for this opportunity to be here and for me to talk about my experience, mostly after leaving CAMHS. So let me begin. This is, to me, a journey of self-discovery. So what prompted my child and adolescent psychiatry journey was really, I think I was always interested in psychiatry even as an MBBS student. And then I did, even during my internship, I attended the psychiatry posting. I was, working in a clinic when I was preparing for NEET. And then I joined MD Psychiatry, and on the first day, the director asked me a question: what specialization do you want to do? And I didn't even know there were specializations in psychiatry. I thought it was an end specialty. Then I said child psychiatry, just out of the blue. But after that, it got solidified because we did our child and adolescent psychiatry posting under a child and adolescent psychiatrist, Dr. Jayantini. And the unique thing about this posting was that after our clinical work, every day we had a schedule where we had to learn a topic. It was already put up, and we had to teach it to Dr. Jayanthi and Dr. Kannan. So this was something we had every day. So throughout the posting, we'd have to teach them. So there was no other way. We really did have to learn. So our theory was intact, and clinical work, they would guide us. So I think that was really one of the stepping stones to work on this. And then when I did express my interest in child psychiatry, I didn't even know there was a DM course. So somebody came up to me, one of my professors, and said, why don't you try? And that then led me to come to this place, CAMHS. And of course, the idea that one gets when one is at CAMHS is the idea that lots of people from all across Asia come seeking treatment, and they come with a lot of hope and the immense trust with the practitioners there. And the idea that one gets is that one has immense resources, like ma'am was talking about, a huge team. So we have 5-6 people who can work with families, and then people go, with a lot of satisfaction. So this is the idea that one gets when one is at CAMHS. And then, so with all of that, I moved out of CAMHS to go to a 2-tier city called Coimbatore, where there were clinical psychologists, where there were neurologists who saw children and treated them. There were Instagram therapists who saw children. There were parenting experts, gentle parenting experts. There were pediatricians who helped young people. There were occupational therapists. We have an occupational therapy college here. So there are loads of occupational therapists, speech language pathologists, special educators. There are teachers who also come in as counselors. So I wondered, where do I fit? And I know when I came in, among the faculty, among the other doctors also, they were like, we didn't know there's such a thing called a child and adolescent psychiatrist. And what do they do? And this was something for me to figure out too. What do I do in this kind of a setting, and where's my place here? And the other thing that I discovered in some time, because I was still in that CAMHS group, where, how do people perceive me when I'm a practitioner outside of CAMHS? So I realized psychiatrist has stigma. And if you add child before psychiatrist, child psychiatrist, there's more stigma, because this is a person who medicates kids. So, there was a lot of fear and apprehension to send somebody to a child and adolescent psychiatrist, because, this is a person who's going to medicate kids. So I also realized that I had to deal with that. So then what I did was, of course, I had come with a dream of working in a medical college. Like ma'am was saying about lack of space for a trained psychiatrist. So the medical college that we had said, we've filled up our MCI norms, so there's no need for an additional psychiatrist, let alone a child and adolescent psychiatrist. So I joined I developed a child and adolescent psychiatry unit in a private hospital with 30 beds. It was a psychiatric hospital. So we had a 30-bedded facility. We had a clinical psychologist, an occupational therapist. All of these people were already present before I came in. There was a client base. We participated in a school mental health program. So it was great for me to make connections. It was great for me to be well known and present to other people so that they could know that I was a child and adolescent psychiatrist. But what I could see was that while I was practicing, most of my practice was looked from an adult psychiatry lens. So why is there so much time spent on clients? Why are people seen by appointments only? There was a lot of push to have IP care for children and adolescents. And so I felt quite stuck there because I couldn't implement my ideas there. The way of practice that we had we were used to. And then I also worked in a in a pediatric department where I got to liaise with pediatricians. They got to know what I do, but also what was happening was we would get only cases which had emergencies. So there was no like a pediatric practice where somebody sees when you're ill and then you go away. So that was the kind of practice they were used to. Somebody will come in as an emergency, there'll be no follow-up. So that was something that I saw there. And a lot of nail biting and bed wetting. I was like, I wasn't trained to do that. I was trained to do, a lot more than that. But then finally, with a lot of push, like I had to speak to a lot of senior mental health professionals in Tamil Nadu to get myself into a private medical college as a child psychiatrist, which I did. And then I was given that opportunity. So here, finally, I got to see only children and adolescents. We had seminars every month, which I could chair. I had supportive colleagues. We had a 3-month posting for PGs. And I'm so glad to talk about that. I mean, in my tenure, we had I was able to guide a few students, and one of them is possibly going to join a fellowship in child and adolescent psychiatry in CMC Vellore. And this is the first for that college, for that to happen, that somebody from there is going to join that. So, and then, so we had IP care. So all of this was there. But in order to get in some innovation, as in we had to go through the dean, and then like ma'am was talking about remuneration, right? So it was always something. So how much will this bring? So any additional support resource. So if I needed a clinical psychologist, it always would be looked at as how much will this bring? So we had to, so that was something that was very difficult. So I had to there also work on it all by myself with a few assistants from PGs. There was no appointment-based system, no space for innovation really. To the point that where we had a child for school refusal, which we admitted. So we had to discharge her every day when she went to school and readmit her when she came back. Because it was a general hospital. They didn't have a policy of permission. People sick, people going on permission and coming back. So then finally I realized that I really like doing things my own way. I didn't like it, things from an adult psychiatry lens. I thought that just didn't work out for me. I needed a lot of flexibility and an appointment-based system. So then I moved to private practice. But this journey taught me that practicing child and adolescent psychiatry outside of certain institution needs a lot of creativity in terms of how do you, when you cannot employ clinical psychologists, how do you still collaborate with other people? Because collaboration is the bedrock, I feel, of child and adolescent practice. So we still had teams, even when I hadn't had the chance to employ support professionals. So we would still work as teams. So I had a clinical psychologist, I worked with some occupational therapists, speech therapists. So we'd still have a team and we'd constantly discuss. So whenever they referred a case, they knew they had to talk to me. When I referred it back, I would talk to them. So I feel there was a lot of space for creativity and collaboration. We would talk to schools when they referred people. We would give feedback to teachers. We did this. It was time intensive, but we called. And so it was development of a new system itself, which didn't exist previously. So, I mean, which we revised over and over till it got better. And it is still it's evolving really. The appointment system. So initially we had to start with explaining what an appointment was. So that's where we started. And I think for some time I used to work independently. So I was the only person. So I think there was a lot of burnout, and supervision with seniors, with local senior psychiatrists is something that really helped me along this journey. And I think management skills, people management, liaising with people, managing a private practice. So I felt some of my experience at NIMHANS working as a team really helped me with that kind of management when I moved out on my own. And to also look at, I think, financial viability is something, especially with the child and adolescent practice, that takes time. So that's something also that I learned. And so with a lot of trial and error, I think we now have an adult psychiatrist who sees the parents, a clinical psychologist, me, and then we have a lot of liaison professionals, special educators, special schools, occupational therapists, speech therapists that we work with. I have a few mentors, local and otherwise, who help me with each of these problems that we face. We have now a child-friendly space. And I think there's a lot more openness to evolution, as opposed to when I came from NIMHANS, I said there was only one way of practice and this is the best way of practice. As opposed to saying, how do we individualize this practice to the setting I am in? While we keep the essential principles of collaboration, creativity, and individualization to that setting, really. So I think that is something that I'm a lot more open to. And to conclude, so this is our space, and what gives me joy every day in practice is to look at young people. So that's a grid board that you see on the other side, which young people write for other young people, which is an idea that I got from Children First Delhi, Dr. Shelja, when we attended a course with her. So these people write to other people about what really helped them. And I thought I'd just read one thing that somebody wrote for somebody else to say, within these four walls, I found a space for honesty. I've discovered a lot about myself that I've never known before. I'm able to say and discuss things that I cannot do on my own, out of fear, out of shame. Something I've learned is that when there are people who are ready to listen, it's time to speak. Without that help I receive in this room, I'm not sure I'd have made it to this day. And this kind of transformation is really what I think continues to keep us in this kind of a difficult practice. Thank you so much.
Okay. So to meet the treatment gap, I have some suggestions. And this is something that actually I don't need to read through. Most of us know. But this part, that is the child psychiatrist and other mental health professionals, training other professionals like GPs, pediatrician in early diagnosis and intervention is, I think, something very necessary because, as I said, we are a long way off from getting specialists. So there must be people from other walks of life who are medical or non-medical mental health professionals who can jolly well do a lot of the work that needs to be done. Training in community setting of functionaries who handle children is another issue. And use of telehealth and service for both service and training is also something that needs to be done until such time that we have that critical mass of child and adolescent psychiatrists. And as Samya just now has spoken to us, we are a long way off to reach that kind of a stage. So I thought I must talk a little about my early years, how my interest was kindled. I had an elder sister who had a textbook of psychology by Coleman, which used to be just lying around because she was doing her BA at that time and I was still young. And I looked through it and wanted to be a psychiatrist from the first day of my medical college. I worked in pediatrics for some time before I entered CAMHS. I chose child as a topic for my dissertation. And I was the very first senior resident that CAMHS had in child and adolescent psychiatry. So I think I must have begged, bullied, shown people the need of why we need a senior resident in child and adolescent psychiatry unit at that time. And then I might have gone abroad for training if it wasn't for Dr. Ilana Cariappa, who by the time I had joined had already gone to the UK, done her child training and come back and was a faculty member there. And I had two very good models in Dr. Ilana Cariappa and Dr. H.S. Narayan. And I'm always grateful to be a person who earned my bread doing what I liked. I think that I'm very fortunate that I did something that I liked and also earned my bread. I have one earnest suggestion of people who are private practicing child and adolescent mental health professionals. I believe that these people who are trained and who are good workers in their area can volunteer in medical colleges where there is an MD psychiatry training program, in departments of psychology and in schools of social work, and offer courses or say that they will chair a seminar or take a class, just 1 or 2 per term. And most colleges will agree for that. And that will be a way in which you can motivate or show young people what can be done. So do not wait until conditions are perfect to begin. Beginning can make the conditions perfect. And with these few words, I'd like to stop and say I'm happy to have been here with all of you today. Thank you.
Thank you, ma'am. Thank you so much for a wonderful talk. If anybody has any questions, they can ask or write in the chat box, please.
I was wondering, listening to Shobha and also then to Soumya, I think a lot of the people who are dabbling or thinking of a career in child and adolescent mental health are often thrown by the fact of the range of community services that can be done, in contrast to adult services, where, because you can do it in schools, you can do it in juvenile remand homes, you can do it in pediatric liaison units, you can do what Shomitra does in a very specialized cancer care setting. And I have seen that a lot of this fear of kind of, that they will not be able to deal with things properly. So I was wondering, how can we encourage young trainees to kind of try out more things and make them convinced that child psychiatry really does not only belong to clinic settings. And one has to reach out a lot more, because that's one of the major fallacies of training in MPhil courses or MD psychiatry training courses, at least in my experience.
So Jairanjan, wherever, such courses occur, that place should also have exposure to these areas so that they get a chance. Like, for example, our DM course at the moment has people having to go to the child work and the CWC, the JJ Act people, the homes that they have to go, and to the school mental health program. So they can get a flavor of what can be done. And that is something that I think one must advocate for. And if you look at MA, MSc psychology, you have industrial psychology, counseling psychology, you have all kinds of, so it can further go on. It can be further, they can further get specializations, but it must be there for them to participate or even see. So far it has been very restricted, as you say, but I can see that now the space is opening up, and I'm hopeful that social work, psychology, medicine, and the community kind of work that they can do can motivate people of different kinds to take up different areas. Educational psychology, I find many young people doing. There is a great scope, and they understand the schools now definitely require psychologists to be there. So counseling psychology, school psychology, yes. But clinic, the looking after the patients, the therapies, I find therapies sadly lacking in terms of actually being taken through and supervised, accredited kinds of therapies. That's an issue. That's a worry also.
Thanks.
There is another question.
Yes, if I can say a few words. Shobha, it's so wonderful to see you after many years. It's absolutely heartwarming to hear you. And of course, it seems that you've covered pretty much everything that needs to be covered. I'm wondering what the rest of us will speak about. But I have one, I have one little question. You listed out the qualities and things that often you have found in people who choose child psychiatry. And I was wondering that if you can think of some ways of screening for such qualities in people who get into mental health of any kind and offer or kind of expose them to the possibility of child mental health, so that we have a larger number of people the next time we gather in a forum like this.
Yeah, I mean, we toyed with the idea of not only just having an entrance exam, but actually working with these people who have an interest and see whether they really will be suitable. Because cracking an exam is different from actually working with the young people. And that we have repeatedly found, and I'm sure all of you who work in government institutes know that there is no other way other than taking them through a multiple choice question. So we wish, Amit, that there is a way in which we could get people who show this inclination in different ways, and we get a chance to work with them and understand whether they will be really suited for this. I agree with you, not everybody who comes in, but I have found from psychiatry, there are dropouts, but by the time they come to child psychiatry, things are clearer for them. Now they have done 3 years somewhere, and then they want to specialize. So we get a good filtrate of people who really are interested in the specialty. But the idea is to motivate others, and you can motivate others only if you're around them. And being around them is the issue. You see, if somebody hasn't been exposed to child, how will he think of getting into child?
That's true. I think forums like this therefore become very independent, and when we work as a private organization, sometimes become very isolated, and we have experienced that. And now that we are trying to recruit more psychiatrists in our team, we find that difficulty because we hardly have any communication or contact with medical colleges and
very true. But Amit, I have found one thing. If you actually go to a medical college and talk to the head of department of psychiatry and say, I want to take 1 or 2 classes per term, oh, they'll be so happy to have you, because they are always looking for some injection of good, interesting matter into a rather boring program. And to have somebody come out with this and say, I'll do it, they'll be very pleased. And, a guest as a chairperson of a seminar gets the attendance also good, they tell us. And so there is a possibility that you can actually motivate people, and many have told us, I've listened to you in such and such a conference, and I thought I must come and do something there for a few months just to see what it's all about. Yeah.
Thank you so much.
If we can take up this last question. Vishri has asked that, do you think a spectrum of professionals similar to UK NHS system is welcome in the Indian system of child and adolescent mental health sector? She is basically talking about multidisciplinary team in Indian context.
I can't hear you, Vivek. Are you talking about Anunya's?
No, it's Bhagyashri.
Okay, I can't. Bhagyashri. Okay. Okay. Yes. So definitely there are many other professionals like child. So there is something like MSc Home Science has a child development course. And I have seen that these people who work in child development have specific things to offer. So the issue is, will NIMHANS take and will NIMHANS allow? That's difficult. One has to lobby for it, because there are set criteria of people who can come. In fact, we don't take undergraduates. The person has to be a postgraduate to come into NIMHANS. We don't take somebody who's doing BA psychology, can't come and do observations with us. They have to be doing MSc. So there are some cutoffs, because people come in droves. There are such large number of young ones who are interested. So there must be some method by which the people can be helped. But I agree, at the moment, a lot of them go abroad and do many courses and come back and are very useful in society. But NIMHANS taking in, unless they belong to the given specialty, is a little tough. But I don't know. I have retired from NIMHANS for some time now, so I'm hoping things will change.
Can I respond to that, Vivek?
Yes.
There are a lot of organizations in India, particularly in the social care sector. They value people who have knowledge in child development, and then these professionals go on and develop various different skills. There's an organization in Mumbai, which actually has 2 occupational therapists in a lead role in mental health provision for young people, therapy services. So I personally believe that if you have a basic grounding in child and adolescent, child development, child and adolescent mental health, then one can develop skills and be a very fruitful member of any multidisciplinary team.
Yes.
And I think that way opportunities are opening up. Again, Amit will be able to kind of share his experience, because he runs he runs an incredibly large number of people. He has an incredibly large number of people in his team, where skills, I think, are more important rather than the specific degree.
Yes.
Yeah, perhaps I could reflect on that a bit, Jaja, as you said, during the panel discussion, if time permits.
Thank you all. Over to Dr. Dutta, please.
Thank you so much, everyone. It was a wonderful talk, as always, by Professor Shobha and Soumya. And the journey of somebody who started some time ago and somebody who is, have had that in the recent past, and both have similarities. And I think the audience here would understand that it's your story which you have to write in some way or the other. Although opportunities are there, but it's important, the fact that you are attending this webinar at 8 o'clock sitting, I think that's testimony, that fact that you are all interested. Now, the next part of the webinar is about becoming a child and adolescent mental health professional. What do you need to think of? And we have 3 very eminent speakers and panelists. So the first is Professor Satya Raj. She is a faculty of child and adolescent psychiatry in Christian Medical College, Vellore. She happened to be a few years junior to me when I was training for my MD. Satya had always been a brilliant student, had the Sharda Menon Gold Medal nationally for a DNB. She did a DPM, MD, FRNZ, CP in Australia, and has been a consultant in infant mental health, which we will hear separately in a focused webinar, hopefully in 2023, which Satya has promised that she will do. So she will be talking about her journey in Australia and in India, how she managed and what she looks forward to. The second is Dr. Nithya Purnima. Nithya has an MPhil and PhD in clinical psychology from CAMHS, Bangalore, and she was the Donald Cohen Fellow in 2008. So both of us were Donald Cohen Fellows in the same year in Istanbul. And Nithya has an interest, someone has given in the chat in our last session about it was so tiring to clear for few seats I assume that's for the super specialty training. And Nithya has developed an interest in mental health of mental health professionals and how do we self-care ourselves. Her primary area and clients are children and adolescents, and she works through a lens of mindfulness, promoting early identification, and working with a plethora of professionals. Till very recently, she was a faculty in CAMHS. Currently, she is an independent practitioner. And the last and not the least is Dr. Amit Sen, who is the co-founder of Children's First. I would encourage all of you to go to the website of Children's First. It has a fantastic introduction of Amit, trying to be all sorts of things. And he has been very humble in saying that he has acquired degrees in UK after MBBS in AFMC, then training in MD in demands. And while growing his family, he acquired 2 more qualifications in UK and has a large team in Delhi. I hear that it has almost 50 people working, and he has a model of working from 0 to 25-year-old people. And that obviously is something because, we can talk about during the panel. My co-panelist is Dr. Jayaranjan Ram, who is the co-founder of Mental Health Foundation. Dr. Ram is a good friend and a colleague in child and adolescent mental health. Dr. Ram is a rock star of child psychiatry in Eastern India and India, and is very well known as a clinician. And the Mental Health Foundation has in reaches to various organizations in training and upscaling other organizations. Over to you, Dr. Ram.
Thank you for Soumitra embarrassing me. Next time I will take revenge. So your time will come. So thank you. I think it's a fascinating kind of discussion, really, and I would like to thank ACAM for thinking of such webinars, because it gives all of us, really, even those who are in the profession for many years, to review how we encourage young people to come more into child and adolescent mental health. Because at least I think in India, there is a huge unmet need. So we will come to that a bit later. So to begin with, Satya, I just wanted to ask you, at what point did you realize that you wanted to do child and adolescent mental health or child and adolescent psychiatry? What was that inflection point?
Sure. Thanks a lot for actually inviting me for this panel. And as I said, thanks a lot to the team as well. Lovely meeting as child psychiatrists here and meeting a group of young people who want to be child psychiatrists. So how should I say? I think my journey, if I look back, I would go back to what Shobha ma'am said. I think I had a child psychiatrist in the college where I studied. So maybe not even in the child psychiatry posting. I think I wanted to do something with children, but not basically pediatrics, treating cough and cold. I thought I need to be relating with children at a different level. And then I saw this child psychiatrist who was really charismatic, and I really wanted to pursue it. So it was from, say, first year of my medical school where I was like, I want to do MD psychiatry just because I wanted to get into child psychiatry. So it's the other way around. So that is how my sort of passion began, I would say. And after all that long journey, and I think I've been one of the blessed ones to be in an institute, to have a very nice, very strong multidisciplinary team. And from day one, as soon as I finished my MD in psychiatry, I've been gifted to work in a multidisciplinary team with clinical psychologists, special educators, OTs, PTs, speech therapists, and we have both an neurodevelopmental setup and an emotional and behavioral setup. So I guess I've been blessed to be in this institute as well. So I hope that answers your question, Dr. Jay.
Just another question, Satya, for you. See, as Shobha said, and all of us can vouch, really, it's a very, very system of. What has been your biggest challenges in kind of establishing your role, and what have been the main kind of maybe potential stumbling blocks in your work? Essentially, we know that it is a multidisciplinary work and you need to rely very closely on your colleagues to support you. So what are the problems? What are the potential problems one needs to be mindful of, and how we can prepare ourselves, at least our minds, to overcome those?
That's again a very interesting question, I would say. See, if I say the benefits of being in an academic setup, so everything was there. You just had to be a team player and join in the team. But having said that, if you're in a different setup, what could be the challenges? So personally, from your side, as a clinician working with children, there are a few things which you have to have. As possibly Shobha ma'am said, it's going the extra mile, spending the extra time, being able to sort of go to the level of the child. So when I'm talking about child and adolescent, I'm mentioning in passing, saying it is a child, but then it's a very heterogeneous population. So it's something like a moving target, should I say. So when you're talking about a child and adolescent, a practice from 0 to 18, it's so varied. So I need to be in different shoes when I see a mother and infant diet or a toddler, to being very different when I'm sort of going to be playing the squiggle or drawing with them or playing with clay dough or messing up with some drawing and crayons, being ready to dirty my hands and getting down to the level of the child in a school-going child, to being sort of across the table, having a session, letting the adolescent talk, maintaining the confidentiality. So across the age groups, the way you relate to a child can have a lot of challenges. So this is personally as a mental health professional working with children. But as you said, the dynamics of working with a multidisciplinary team, I think that is something which again is the trick of the trade, should I say. So you must be able to have the ability to coordinate with people. And as ma'am very nicely put it, if you're able to sort of leave the ego out of the team, come in as just people for the child. And as the name says, Dr. Amit said, children first. If you're able to do it, I think it's job well done.
Thank you, Satya. I will come to Amit next. I think we have known each other for last more than 30 years now, and for him, he is undoubtedly established a fabulous team whom we all envy. So Amit, I know this is a very, very kind of difficult question for you. Couple of questions built in, I will just ask you together. One is, how do you see your entire journey? Kind of, when did you decide that you will start a separate setup? Because it was quite a brave decision, setting up a team in a very, very competitive city, metropolitan city, where the costs of establishment are very high. So what made you do that? What were the key key points. And, I believe that the second part of the question is, I believe that the aim of building any organization, the team leader should have the view to make himself or herself redundant. So when are you going to apply for redundancy? That you are no longer needed, and you have built children first. It can run without you. So yeah.
Yes, I think I'll probably answer your second question first. From the time that we had actually established a multidisciplinary team and set up Children First, from that time on, I think and when I say we, I don't think I'm the only person who leads the Children First, or I'm the only person who's developed it. There have been many people in this journey, and I've been fortunate to have my partner, my wife, Shailaja, as right from the beginning. So, brainstorming, conceptualizing, drawing courage from each other has been a big part of our journey. And of course, we were also fortunate to have many other very capable and motivated people join us from time to time. So we've set up this team and perhaps looked out for people, as Shobha said, people with such qualities who are really passionate and motivated to work for children, for children's rights. They get very upset and angry if they find that children have any child has faced any injustice, and we try and translate that passion and that anguish into services which are again over the years has often been driven by child rights and a framework of social justice. Yeah, but I'll go back again to our time when we first, of course, my training has been in CAMHS, and that was one of the most exciting phases. And Shailaja was also my batchmate at CAMHS, and I remember the curiosity with which we looked at the child psychiatry department, which was so vibrant, different, and colorful as compared to the rest of CAMHS those days. And I remember when I got posted, and that was shortly, immediately after the family therapy posting that I'd had, and I was most impressed by the non-hierarchical structure. And as Shobha said, where people would drop their egos outside the room and they would come together as a team. And to my surprise, many of my own friends and colleagues had, the ones who were doing their, DPM or MDs in psychiatry, had a huge discomfort with that, lack of structure or hierarchical structure. And I think that was what actually excited me the most, the collaborative approach, the fact that we could look at children from different angles and lenses and see the holistic picture and the hope and possibilities that arise out of that. That was one of the most exciting things that, made me convinced that this is what I wanted to do, along with psychotherapy. So it was a good marriage, I think, So, of course, we went off, both of us, to train in UK, and we worked there for about 7.5, 8 years, and we returned with the single-minded purpose of developing services. And indeed, in the beginning, when we came to Delhi, in the north of India, there was no standalone services in child and adolescent mental health who were only doing that. So there were services in PGI Chandigarh, there were services in Delhi, there were some people who were, who had child guidance clinics and all that, but most of them would also devote part of the time to adult and general psychiatry or mental health, and then also, run the child psychiatry. So, but we were convinced that this is the need of the hour and we have to do it. And so despite many of our, friends and colleagues telling us not to put all our eggs in one basket, we were determined to do it. And I don't know where that came from. I think that we were convinced that this is what is required. If we really want to build a multidisciplinary team, we want to, kind of respond to the need in the community at that time. And it took us a while. We worked, I'm sure you remember, Jaja, and some of you might not know, but we started our service from a multidisciplinary hospital, a multi-speciality hospital rather, called Sitaram Bhartiya. And they gave us the space and to build this team. And we did that for 5 years in that space. And then we realized that services have to be, placed in the community for children. Because children often feel very scared and daunted by coming to a big hospital where, there's a regular OPD and, there are doctors with aprons and stethoscopes. Oftentimes, particularly children who perhaps, perceive the outside world with a degree of caution and skepticism, find it very hard to cope with it. So we placed ourselves outside. We also wanted to grow because the hospital could give us only that much of space and time, space and facilities. So the whole team moved out. So we were not a very big team at that time. We were about 8 to 10 people, but we moved out and we formed Children First. In the beginning, we were really a mom and pop shop, but soon many people started showing interest in wanting to collaborate with us and fund us. Now, when that started coming in, the question that you asked as to how do you balance it out? There were many people who said, you know what, this is going to work very well. If we pump in some money and you make it lucrative, we start getting returns after 2 to 3 years. And we said, hang on, that's not what we want to do. Although we are private professionals, we are not looking for a profit-making model here, right? So we had to wait for a while before we could collaborate with people who said that we are investing for the purpose of building services because we can feel the need, like you, but we are not expecting any big returns of any financial nature. So from the time that those investments started coming in, one thing was made clear that nobody is going to make profit out of Children First. So any sort of extra that we make in terms of fees or other kinds of financial resources will go straight back into the making and building of the team. So of course, over the years now we have a team of about, if you count the whole administrative team, we are probably about between 55 and 60, but we have 40 people who are trained professionals and therapists, 40 odd people, out of which 4 are child psychiatrists, and we have about, I think, 8 or 9 occupational therapists. We have different categories of psychologists, and we train them from the time they, so we often take people who are fresh from their masters or their post-graduations or MPhils, and we believe that they have to do a bit of unlearning before they start in, getting familiar with our style of working, and what else? I do think that we've strived to
No,
make
I think
we've also worked a lot in the community, done a lot of training. Sorry, I'll just put that little 2 bits about the training and the community work that we do, and we believe deeply in that. There has to be preventative work. That's one of the most exciting parts of our journey as well, of working with schools of all categories. We've worked with private schools, we've worked with Delhi government schools, NDMC, SDMC schools of all kinds, got funding from outside to be able to make that possible. We work with various NGOs and formed models within those organizations, and those are most gratifying. And even with the young people who come in, perhaps because of the way we choose them, and perhaps because of the way they learn in our collective, that they've seemed the most excited about going out and working with organizations who have very little in terms of expertise or professionals to help them.
So I think that's I think there is an infectious enthusiasm which inevitably seeps into other organizations, other professionals whom you bring into the team. And I think that is something very great about your entire team. I think Shelja, you, Kavita, whom I have been fortunate to meet. So I think this infectious enthusiasm is very much needed, as Shobha also mentioned. Now I'll come to Nitya and ask her, you have been, as a therapist, Amit said something about wanting to unlearn. There are things to unlearn. So as a therapist, what do you think are the special skills one needs to have in order to see a child compared to an adult? And did you have to unlearn anything which maybe you picked up in an institutional setting compared to when you went back to the community as an independent practitioner? Because that's quite a brave step.
Nitya, you have to unmute yourself.
Thank you. Yeah. Thank you, Sumitra, for that reminder. So thank you for this opportunity to be here. I'm glad to be here this evening with this community and to reflect upon my journey of being in this space of child and adolescent mental health. So yeah, so maybe I'll speak about the skills required to work with children and adolescents first, and then go back to what I needed to unlearn. And I'm still in the process of setting up a full-fledged independent practice. It has been a jump, and I'm taking it as it comes. But with regard to the skills, I think there are a core set of skills I find very valuable. First of which, like Dr. Satya was mentioning, is to be able to take perspectives of different kinds of people with the same child at different points in time, children from different developmental stages and different developmental capacities. So it's really a very wide bandwidth that the child and adolescent mental health professional needs to have to be able to take those perspectives and to respond with respect and empathy. The other key skill I find is that of emotional awareness and emotional regulation for oneself. And also because oftentimes the child and adolescent practitioner is supporting the child or one of the family members regulate themselves. So which means one needs to offer their mind to the other person to regulate themselves. So I find that that's a very key skill. Communication, being able to really key in on nonverbal communication with young children, even with adolescents at many a time, even with parents many a time, being able to tune into nonverbal communication is a very key skill. Oftentimes as early practitioners and as young trainees, one does feel flummoxed that they're not speaking anything, they're not saying anything. And what do we do? So really getting into that dance, I must say, of picking up cues and responding, beginning with small, subtle nonverbals, and then gradually using speech, language, which is suitable for each person. So that's a big skill set. And not only with children and their families, but also with other team members. You know, we've repeatedly heard how working with children and adolescents is a collaborative effort. One needs to be part of a multidisciplinary team. And it's only when that team is in place and is working well that the child also benefits. So being able to have open and effective communication with everybody. So I think these are the core that I would hold to. There are many more technical skills and so on, but these are some that I would point towards. Unlearning from an institutional setup to independent practice, like Samya was mentioning, knowing that you really have to carve out space and time for the kind of practice that one knows is ideal, and to also see how that can be modified. Right? So being able to, for me, being able to use creative methods of assessment so that I'm able to tap into certain aspects of the child's functioning, the family's functioning, without doing a long drawn out interview, which I may not have the time to offer a family to. I think these are small elements that go a long way in making the experience helpful and satisfying for the family, for the child, as well as for the practitioner.
Thanks, Cynthia. I will ask this next question to all three of you, and actually to all the panelists, including Shobha and Soumya. One of the major differences between UK and India in child psychiatry, or in any, particularly what has been very apparent to me personally when I came back to India, is that in India, it is an out-of-pocket expense for parents. So often parents bring their child to us, to mental health professionals, to fix them. How do you really maintain that balance where, Nitya also said about having multiple perspectives? So the parents' version, the parents' story is also true, while the child's story is also true. And Amit mentioned about social justice, equity. I have initially found that finding that right balance, a bit wobbly. Not that I'm perfect now, but I would like to hear all your thoughts about, in this situation where the majority of people are paying out of their pocket, how do you keep the family engaged? Because in many situations I have seen, if the child is not fixed within their perception, they just go away. So, which is something very, very uniquely different. And we don't have statutory measures like in UK, where social services can make recommendations, schools can make recommendations, which is not possible here. Anyone really. So
Should
Can
I
I?
start?
Yeah, please.
So that's a very interesting question. I was thinking about it in two ways. It is not a one-step process. It usually doesn't happen within the first few interviews as well. And the parent comes in with a different agenda. Of course, the child comes in with a different agenda. You have an agenda of collecting a history and making a diagnosis. This doesn't marry well, right? So when we're able to sort of put the child's perspective first and able to build a trust with the parent that you are here to help the child, it might take a few sessions more or less, but then the outcome or the end point is the child being benefited and the family sort of getting a holistic care. I think impressing the family and the child that it is in the best interest of both that we are working. If we are able to do it in the first few interviews, I think that's the success, and that's why people tend to hold on, and that's how we can make it happen. But it's an initial investment, I would say. The first few sessions we're able to do this, I'm sure they'll be able to continue, though it's an out-of-pocket payment, right? So that's my take, but love to hear from others.
Yeah,
Thank you.
if I mean something, so I put the bar really low. So if when I'm seeing a child with the family, if the child and the family is willing to consider that they would be coming back again, I think my first interview has succeeded. It's not about diagnosis. Secondly, taking about this multiple perspectives, I think if somebody gives information, see, this is happening, the child is crying at some point of time, mother says, the other family member is unaware and says nothing happens. So I would value somebody who gives the information over somebody who doesn't have that information. And not to be dichotomous, saying that one is truth and another is not truth. So, I think this takes a sort of, for trainees who are here today, so I think this takes a learning of going by this multiple perspectives and evolving. So, many ADHD children's parents wouldn't find them that difficult, but if you get a teacher, so it's about power. So in the school, the teachers might this thing. So in Indian setting, if a family comes, particularly in a setting like cancer where I work, a child has leukemia and the family is anxious and has come, you have to hear out the parents as well. And if you do that, at least you ease the tension in that you taking the one down approach, trying to say that you are actually a specialist about your child, and let me learn from you and suggest how ways we could make it better together.
Yeah, thanks. I think that's a very valid.
Yeah. So if I can also share my journey about the positioning as a mental health professional, because I think when we got trained, and a few of us here in this panel have got trained at CAMHS, at least I had this feeling that I'm a real expert and I know it all, and from that to going to UK and understanding that perhaps those clinicals, I mean, while the clinical skills are very important, and it's important to, get the symptomology right and the diagnosis right, there's much more to mental health than that. And indeed, one big thing that we learned, which came as a slogan in UK, was that we work for the best interest of the child. But then the question came to me much later, as to who decides what is the best interest of the child? Because there are many stakeholders here, isn't it? Right? And is it the parent? Is it the teacher? Right? Is it a professional like me? Or is it the child himself or herself? And increasingly over the years, I think I've banked more and more on the child's version of what the situation is. I mean, you have to take the parents along, or you have to sometimes take the school along. And there could be many other stakeholders which are important for the child's well-being. But to be able to listen and give the due importance to the child's version of the story, keep it at the center and weave the other stories around it. So a lot of the times what we do is dovetail, what the expectations of the child is. So many times I start by asking the child, so particularly adolescents, or even sometimes the so-called tweens these days, walk into your clinic or your center with so much of resentment. They don't want to be there, right? And how do you engage such kids? Like reading to the sports page, to listening to all the latest music and the books and all of that, yeah. And the TV shows, the angsty teen TV shows, all of that, and then you come back to that and begin to engage with the child, and then get down to more serious business while the parent is listening, and to be able to reflect together and say that, oh, it seems that you have common goals. I mean, this kid, and you thought he was wanting to drop out of school. Actually, he wants to be a photographer. He can't drop out of school if he wants to be a photographer. Let's see how we can bring this together, for both of you. I mean, how do you think we can work, to help him become a photographer? Do you think parents, you can do something about it? So that kind of an approach often, at least for most of the time, works in a manner where the young person, most importantly, the young person wants to return. I think that's the key, yeah, and the parents often follow. So that learning has been huge, and the unlearning as well and to take a non-expert position and say that I don't know much about your life. Just like Soumitra said, that the parents know. The parents are the experts in their child's life. There's no question about it. And I think more than that, the child is an expert in their own, about their own lives and their world, their fantasy, their stories that they have, their peer relationships is something that we often don't even have can't even have a glimpse of till the time we begin to engage with them in an altogether another way. And that's what we try and practice. At Children First, we try and make that an approach. And we work through narrative practices, and we work through stories and all of that. And we believe that perhaps helps in this dilemma. The dilemma is still there. It's not as if it's easier every time. Each child is different, each family, and their reality is so different. And they come from.
I'm just mindful of the time because it's 2025. We'll just touch upon. I think Professor Shobha showed briefly the slide on where child psychiatry trainings are available. If Satya can, just run through that, meaning is the entrance all through NEET and an MCQ? But I would also be very keen to learn from Nitya that after MPhil, if say today's professional wants to become a child psychologist, what are the options available in our country?
Thanks, Dr. Soumitra. I think Shobha ma'am had mentioned it. Just to highlight, we have postdoctoral fellowship courses. So you have 1-year courses, which is run by basically NIMHANS, JIPMER. You have it in St. John's. You have it in Asha Hospital in Telangana. You also have it in Nayar's Hospital in Mumbai. So these are the institutes which offer a 1-year fellowship in child and adolescent mental health. Of course, CMC offers a 2-year postdoctoral fellowship in child and adolescent psychiatry. In the country, in India, at present, I think PGI Chandigarh and NIMHANS have a 3-year DM program. The new initiative, I would say, is Indian Association of Child and Adolescent Mental Health. They have a certificate course. So this is basically online. This happens, it's virtual. They have lectures from everywhere, and then they give a certificate at the end of a year for training in child psychiatry. So that is one nice initiative where a lot of pediatricians, registrars are interested doing MD, wanting to know more about child psychiatry register. And of course, there are a few NGOs as well, as I know, Pathways in Coimbatore. I think they also do a good job of giving a certificate in child and adolescent mental health. So this is a snapshot, and please forgive me if I've left out something and our colleagues can add as well. Thanks.
Over to you, Nithya.
Yeah, thank you. So one of the key ways to specialize with somebody with a clinical psychology background is often through their research dissertation. That's the space they get to engage with children, to explore the area of child and adolescent mental health at the MPhil level, but also to be part of projects. There are many projects run by not just NGOs, but also by various academic departments, where there is great opportunity to learn hands-on about various aspects of engaging with children and adolescents, and different aspects of working at the community level, working with clinical populations, working from a legal perspective or an advocacy perspective. So there are those opportunities. And today, courtesy the pandemic, many courses are available online as well, particularly from centers like the Anna Freud Center. There are key programs that are run with specific objectives. So those who are interested in child and adolescent mental health could also look at those. My strong recommendation would be for those interested in this area to try and get an exposure in as many diverse settings as possible, because very often the training is from a clinical hospital setting, but you will find that when you step out into a school setting or into a community setting, working with different spaces, really the sky is the limit. And there are so many opportunities to offer services that are catered to different kinds of needs. And there are many kinds of models that could be developed. So it's a very exciting space. And like Dr. Shobha mentioned, your creativity, your curiosity can all be fulfilled in a meaningful manner, not just for your personal growth, but also for the growth of the community. That's what I'd like to say. Thank you.
Thanks. I think, Soumitra, we have run out of time for the panel discussion, and we now need to So thank you everyone for, I think that was a very broad-ranging discussion and sharing your thoughts. So over to Soumitra.
Thank you to all of you and Dr. Ram. I would now like to invite Gordana Milavik. She is the chair of ACAM in the UK. ACAM publishes the Blue Journal, which many of us are familiar with. And she was the clinical director of child psychiatry services in the Maudsley Hospital. So Gordana will make some closing remarks regarding ACAM and its future plans in India.
Thank you very much, Soumitra. Good evening, everyone. It's been absolutely wonderful being with you all this evening. And I just want to say how impressed I am, Soumitra, with how much you've done with ACAM India so far. And this meeting this evening, it bears witness to some of the initiatives and projects you've been working on. I should add that we're so impressed with Soumitra's contribution that he's now become the international officer at ACAM. So he's not only going to be looking after things in India, but also across the world. And we are delighted to have him on board. So I will not go on because it's just been lovely. You know, I will not repeat some of the things that have been said, but I just wanted to thank Dr. Shobha Srinath for her wise words and years of experience and an emphasis on multi-professional and multidisciplinary teams, which is so crucial. And I think of particular relevance to the Indian community because of the various hierarchical relationships in society and so on and so forth, it's been very difficult to forego that pivotal and central role of the doctor, of the psychologist, of the expert, and to work in a true fashion with the multidisciplinary team and value each member of that team. And we've all gone through this. The kind of dilemmas we've had in our working lives have stemmed from those early days, and team meetings after team meetings of group dynamics where our poor patients have suffered, where we argued with each other mainly. So thank you so much. And of course, we had from Dr. Soumya the clinical psychology perspective. Thank you very much. And the importance on the community complementing whatever we do, and the fact that we need to be out there. Again, as I go through the rest, and the panel discussion, these are very personal views, which I think will stick with all our audience, because that's what makes impressions on all of us, and that's why we make our choices and go one way or another. So it's nice to hear about the personal experiences. I thought the panel discussion was particularly helpful because, once again, we learned something about the Indian cultural sector, the different perspectives of the child, the parent, the fact that you've got to subtly deal with some of these, again, relationships, and take your time and not rush into things. And I will remember, and Sumitra will remember, because we practiced about the same time at the Maudsley, the hoo-ha around child abuse and how we sometimes overreacted to child abuse and made some grave mistakes, as well as helping children. But we rushed into some of these situations and, obviously had the recourse of social services and the courts and so on. But the end results and outcomes for many of these children in care are not so wonderful. And we're finding out, even post-COVID pandemic now, that there's so many children in the care system, and they're not doing well, very, very well. And we need to think about better ways of helping parents. So thank you to all our speakers. It's been absolutely wonderful. Thank you to our many participants. Please remember, this is recorded. It'll be shared. You will be sent a link, which you will be able to access. That includes the slides. And if you do have any other questions about training opportunities, about pathways in your careers, please contact each of us here on, the participants of this wonderful lecture this evening. So thank you all.
Thanks.
Thank you, everyone.
Thanks.
Thank you. Thank you.
Bye-bye. Bye-bye.
Find out more about becoming an ACAM member and to be part of the advancement of child and adolescent mental health. Visit www.acamh.org.